unconfirmed, but appears to be from bats. And we certainly know it has efficient human-to-human transfer. But the good news, 80% of people will have asymptomatic to mild disease and will recover without treatment. So that we need to look at that in the light of treatments that are proposed. The fact that people get better using something does not necessarily mean that thing worked. So we need to do studies to really validate anything that we bring up. Because we know many people, sorry. The clinical signs and symptoms have not changed, except we now record of people do get, and it's quite prominent as one of these signs and symptoms. And of course, we don't understand a little bit more about why people die. We understand about the cytokine storm that they get. Laboratory testing, there are very few commercially available antibody tests on the continent, but many are being moved towards being validated and being rolled out because it's very clear that we're going to need this and we're going to ramp up testing. We also know that we have found viral particles in many body fluids, but it has been very difficult to grow infectious particle from many of these body fluids. So it still stands to, are these body fluids infectious? So far, the evidence suggests that they're not. Because of all the changes as well, and because of this speed and the changes in the epidemic profile, moving from imported disease to community spread, the definitions have changed, have been modified. And for many people, the COVID patient will have no history of travel. He may even have no idea of contact. And so a patient with a severe respiratory illness, and in the absence of an alternate diagnosis that fully explains the clinical presentation, is more likely to be what many of us are seeing, and is what a lot of us are seeing now on the ground. Now, when we think about the speed at which this epidemic is going on and rising, it is very clear with its infectiousness, even with the 20% or 5% critically ill, the 15% that are moderately ill to severe. When we look at our capacity on the continent, if you look at this average number per 100,000 beds, just over 100 for hospital beds, and this is by region, you'll see that we're not doing well at all. So it's extremely important that prevention is where we need to really focus our attention. And so infection prevention and control is extremely critical for our management of this epidemic. We don't have the healthcare facilities to take care of the large number of cases. And if we look at what happened in America and Italy, we really need to be more aggressive about preventing new cases. And what is infection prevention and control? It's not just about PPE. It is actually a scientific approach with practical solutions designed to prevent harm caused by infections to patients and healthcare workers. And it is grounded in principles of infectious disease, epidemiology, social sciences, and health system strengthening. And it is rooted in patient safety and health service quality, really have prevention and control. And at any time when we're working in infection prevention and control, we're looking at how disease is transmitted and recognizing that for as long as that circle is complete, disease will be transmitted. And so infection prevention and control seeks to break this transmission, either at this level, preventing the infectious agent from getting to the reservoir, or making sure that it doesn't come out of the reservoir and is not transmitted. And a lot of the strategies are based on breaking this chain. So how does this virus cause infection? It is primarily through inhalation of droplets expelled from infected persons from their respiratory tract, through coughing, sneezing, talking, singing, but in close proximity, or indirectly with contact with respiratory secretions that have been deposited on surfaces and that can be moved by hands, contaminated hands to the face, and that is inhaled, or opportunistically from procedures that generate aerosols and allow aerosols to stay suspended for long periods. Within the hospital space, these aerosol generating procedures include, the aerosol, and the aerosol generating procedures that are performed. So the transmission of these droplets is always facilitated by close contacts, by having many people in the room, crowds, and by having closed spaces where ventilation is not adequate. And so to break that transmission, you need to keep a minimum distance of 3 feet from others. You have to avoid crowds, congregations, and avoid those spaces, rooms with people in it that allow for a concentration of the droplets in the air. So how are these droplets spread? As I said, coughing, sneezing, talking, and singing, and even breathing, some things come out. Now, some studies a long time ago looked at droplets that were expelled during talking, coughing, and sneezing. And you can see that when you sneeze, a lot of droplets come out. But in addition to that, they're propelled beyond the 3 feet to and move at about 50 to 300 meters per second. Now, what this tells us is that in addition to anything that we do, covering our cough is extremely important. So it's extremely important that we cover with tissue so that the droplets do not move too far, and we collect them in this and throw them away. And of course, do hand hygiene, or cough into our elbow. This way it limits distance that these droplets can travel. So what happens in the environment? These large droplets will fall to the ground or other horizontal surfaces very quickly. And they can begin to evaporate to form tiny droplet nuclei. And these ones can remain suspended in the air for long periods of time and be transmitted around. Now, the large particles tend to land in the upper respiratory tract, where they may be swallowed or they may enter into the respiratory tract and are inhaled. Smaller ones are breathed in with air and land in the trachea, the bronchi, bronchioles, and alveoli, where they cause infection or are brought back to the upper respiratory tract by ciliated epithelium and then swallowed or removed by macrophages. I just want to put this in context because there has been a lot of fear. We've seen people wearing coveralls, etc. But if you think about it, similar infections that are spread by droplets and airborne routes, pertussis, meningococcus, etc., pulmonary TB, measles, we don't wear coveralls for all this. So it's important to recognize that though COVID-19 highly infectious, though COVID-19 causes, nobody wants to have, we don't have the treatment for it now, it is still a respiratory virus. And the main and most important PPE is preventing the entrance in the respiratory tract, the mask. So these aerosol generating procedures that occur in healthcare are the ones that generate aerosols and create the airborne opportunity for COVID-19. Some studies have been done just to show where the virus is found. So we find active virus replication in upper respiratory tract tissues and lungs. And we find that these infectious viruses are readily isolated from the throat and lung-derived samples. And in the first week of symptoms, the virus is shed in very high quantities with a peak on the 4th day. And what's found is that the shedding is about 1,000 times higher than you find in SARS, the first SARS-CoV-1. Blood and urine samples did not yield infectious viruses so far, and infectious viruses have not been found in stool samples in spite of high virus RNA concentration. And what this means, we're not quite sure yet. And this speaks to the transmission, because it's been found that there were higher viral loads soon after symptom of onset. Most of this are found in the nose, or are found more in the nose than in the throat. So that the shedding pattern of these patients are similar to influenza, but different from that of SARS-CoV, the first SARS-CoV. And what the whole picture tells us, it suggests that transmission occurs very early in the course of the infection. And once a person is infected, how long do they continue to shed the virus? Study after study have shown that shedding appears to start early in the course of the disease, and the highest shedding is early in the course of the disease. And that you can actually find the virus 24 to 48 hours prior to disease onset, and speaks to the asymptomatic or pre-symptomatic spread of this virus. It's been found that the peak viral loads occur within the first 5 days. Shedding may continue for 7 to 12 days in mild to moderate cases, and for greater than 2 weeks on average in severe cases. But sometimes it has been found up to 20 days post-symptoms in some people. It was also found that sometimes the viral RNA shedding from sputum outlasted the end of symptoms. So in some people, and that seroconversion will occur about 7 days in 50% of patients, but was not followed by a rapid decline in viral load. What was found in that study was that all patients had seroconverted by 14 days, but we do know that those who go on to have more difficult, more severe infections will remain positive. In the study, they found also that despite high viral loads, no virus was isolated after day 8. And active virus replication in the upper respiratory tract puts the prospect of COVID-19 containment in perspective. In other words, patients may still be infectious after seroconversion if before 8 days since symptoms. All these still need to be, more studies need to be done to ensure that this holds true across board. But it does suggest that that patients may remain infectious even after seroconversion if done too early. This particular paper looked at asymptomatic and pre-symptomatic transmission. And it's just to share the importance of asymptomatic and pre-symptomatic transmission. This was a familial study. Patient 1 was infected, but he was asymptomatic throughout. And even at this point, he had a negative PCR result and didn't have a positive PCR result till almost 3 weeks. These are all the patients who were in contact with him, and some became symptomatic after about a week and a half, and then, but did not become PCR positive till about 4 days after they were symptomatic. And so there is also the possibility of symptomatic people being asymptomatic, having a false negative. Studies have also shown the ability of coronavirus to live for long periods. The study that looked at the aerosolization of the coronavirus created an abnormal situation, but allowed the virus to settle on various surfaces. And the virus could be picked up for about 3 hours in air, metal 5 days, wood for 4 days, plastic about 72 hours, copper for less than 4 hours, cardboard for less than 24 hours. And this has been going around in the media, in the social media, about the persistence of the virus on surfaces. It's important to note that an abnormal situation was created, that in the normal way, the virus is not aerosolized this degree at all. So it's important to have this in perspective, but also speaks to the fact that we need to do environmental cleaning. So who is vulnerable? Everybody is vulnerable, and everybody transmits to others. We all know severe disease is about elderly and people with underlying disease, but more recently, we started to see the impact on children with this immunological reaction to the COVID-19, which is still something being understood, and I'm not sure that any case has yet been reported from Africa, but I'm sure we will get some reports sooner or later. So for IPC, we always go to trying to eliminate the harm and the hazard. It's often difficult to eliminate SARS-CoV. We might not be able to replace it, to replace that hazard. But we can shield people from hazard using engineering control, ventilation, etc. Can change how people do things, and you can see what we do with social distancing and so on. And we can protect the worker with PPE. And of course, this is the least important. Social distancing, keeping the contact, ensuring good ventilation, really speak to dilution of the virus, and ensuring that people are not in contact with other people, reducing exposure. So in breaking the chain, we do a source control. You isolate infected patients, which is what a lot of us would do. Sorry. We treat infected patients. We mask affected persons just to keep the virus out of the environment. We interrupt the mode of transfer by washing hands. We clean environments. We protect the environment from the virus. We prevent the virus from coming out into the air, like our cough etiquette. We wear PPE to protect the portals of entry. We do screening and triage to quickly remove people that are suspected of having the infection, mixing with those who don't. Then we try to protect susceptible people through isolation. So far, we don't have a prophylaxis. A lot of work is going on. We do not have vaccination, but we have PPE. So the idea at the present time is keep susceptible people away from those who are infected. And if there is any reason that a susceptible person is close, they can be masked so that they cannot be in. So strategies for effective IPC in COVID-19. The infection prevention and control during healthcare when COVID-19 is suspected came out. And there are 5 main pieces: ensuring triage, early recognition and source control, isolating patients with suspected COVID-19, applying standard precautions for all patients, because a person with COVID-19 could have other things. So you need to prevent people from coming in contact with body fluids. Implementing empiric additional precautions. These are droplet and contact, and whenever applicable, airborne precautions for suspected cases of COVID-19. Implementing administrative controls, the policies, the guidances, the work schedules, etc., and using environmental and engineering controls. In ensuring triage, early recognition, and source control, triage is for early identification of patients with acute respiratory infections to prevent transmission to healthcare workers and other patients. It's important that healthcare facilities establish well-equipped triage stations at the entrance and entry points, and these must be supported by trained staff and all the necessary documentations. It is important also to encourage healthcare workers to have a high level of clinical suspicion and to institute the use of screening questionnaires according to updated case definitions. And very importantly, you need to post signs in public areas reminding symptomatic patients to alert healthcare workers and or relevant authorities. We must apply standard precautions for all patients. Cough into tissue and discard in covered bins. Hand hygiene according to the 5 moments of hand hygiene. PPE according to risk assessment. Ensuring safe patient care equipment by appropriate cleaning, disinfection, and sterilization. Increasing the frequency of the environmental cleaning with regular disinfection of high-touch surfaces. Managing waste safely, handling linen safely, managing shops, and so on. Implementing empiric additional precautions are really targeted at COVID-19 and should be used not just by healthcare workers, also by family members, visitors, before entering patient rooms or wards. Patients need to be placed in adequately ventilated single rooms or cohorted in a general ward with natural ventilation. All patient beds should be placed at least 1 meter apart. It would be preferable that teams of healthcare workers are designated to care exclusively for suspected or confirmed cases. Dedicated equipment or disposable items should be used, but where they cannot be disposable, then they should be cleaned and disinfected if they have to be shared. Healthcare workers should use surgical masks, eye protection, goggles, or facial protection for routine tasks to avoid contamination of mucous membranes. They should wear a clean, non-sterile, long-sleeve gown and gloves. Boots, coveralls, and aprons are not necessarily required during routine care. After patient care, there's a need to doff and dispose of all PPEs safely and in the infectious bin and perform hand hygiene and use the new set of PPEs between patients. Administrative controls to how people do things and the policies and guidelines that are provided to create a safer working environment. So adequate training for healthcare workers, need to monitor that in addition to being trained that they are complying standard precautions and provide mechanisms for improvement as needed. We need to establish surveillance processes for acute respiratory infections potentially caused by COVID-19 amongst healthcare workers, because we've also been seeing that there have been a lot of healthcare worker infections, and oftentimes it's healthcare workers infected by healthcare workers. We need to ensure that healthcare workers and the public understand the importance of promptly seeking medical care and ensure an adequate patient to staff ratio. The engineering and environmental tools, some of them will in addressing the basic infrastructure of the healthcare facility to ensure good flow and flow from clean to dirty areas, adequate ventilation in all areas in healthcare facilities as much as possible, creating the spatial separations that are required, ensuring the adequate wash infrastructure and environmental cleaning, safe and effective laundry services, and safe medical waste management. Finally, you need to use PPE, but this is based on risk assessment. Based on the risk assessment of the type and duration of exposure to body fluids, use gloves to protect skin from blood and body fluid exposure and to prevent spread of pathogens to other patients. Use gowns to prevent contamination of clothing and prevent entry through cuts in the skin. And masks to protect yourself from exposure to potentially infectious material by blocking droplets, splashes, or sprays to mucous membranes, such as the eyes and the mouth. The control of COVID-19, therefore, needs multimodal strategies. And success in controlling that spread in different countries has come from screening at airports and fever checks throughout selected populations, isolation, contact tracing and follow-up, quarantine, travel restrictions, destination of dedicated hospitals to minimize the risk of spread, and strengthening IPC. There have also been mass media campaigns to educate the public and encourage prompt reporting of symptoms and implementation of transmission reduction measures, cough hygiene and hand hygiene. So to achieve the highest level of effectiveness in the response to COVID-19 outbreak, you need an IPC program with a dedicated and trained team, or at least an IPC focal point who is trained. They should be supported nationally and in the facilities. And countries where IPC is limited or non-existent will certainly require support, such as being given by the African CDC and other disease control agencies within countries. Because for us to move forward, IPC is crucial to success in dealing with COVID-19. And what is important is ensuring that you have at least minimum requirements for IPC, and there are documents to help. This should be both at national and facility level, so you don't have to think through it. There are documents that assist us in achieving this. You need to have these multimodal strategies. You need IPC programs, you need guidelines, education and training, surveillance, you need monitoring, audit and feedback, and all this on a bedrock of an enabling environment. Workload, good staffing, where they don't have too much workload. You have bed occupancy, cannot afford crowds, and a good built environment with materials and equipment. So how do you achieve these? For everything that we do, you have to have a plan. And so you have to prepare for the action. You have to prepare for your IPC program. You know the threat. You identify what you need, both human, financial, the infrastructure, the supplies, PPE, and so on. Then you look at your situation. What do you have? What don't you have? What do you need? What strengths do you have? What are the weaknesses? Where are the gaps? And then you set up a team to develop a work plan. You need to develop the budget. You need to set the target. What are we hoping to achieve? My advice is to make it bite-sized and keep moving slowly till you've done it well. And then work your plan. If you have a plan, work that plan. Go back to the plan every time. How far have we gone? And this can be done through the EOC as you assess the impact of whatever you're doing. There has to be daily reviews of these targets. And to do these, you need to have checklists and observations, regular feedbacks to your emergency operation centers. You're looking at the things you say you want to do and how far you've gone. Then you need to look at what you have done, what you have failed to achieve, why you did not achieve this, what gaps remain, and fill those gaps. And as you go on, you'll be identifying problems, and you sort that there will be errors committed, you correct those errors. The important thing is not to worry, it's not a blame game, to strengthen our weaknesses and improve on strengths. So it's a continuous circular motion it's just to keep the eye on the goal as we continue to try to reduce transmission. So the responsibility of the IPC focal points and teams is the training of frontline workers to share science so that we can douse the fear, to identify the risks over which we have some control and work on them, to take appropriate and cost-effective measures to minimize or eliminate the risks of transmission, and help health facilities to set their priorities and put in place the required interventions. What I've tried to do is just cover what we'll be doing in the next 6 weeks in a nutshell, just to give us a broad overview, to also remind us of where we're coming from the last 6 weeks, and to remind us that the virus we need to avoid close contacts with others without appropriate PPE. We should avoid crowds. We should avoid closed spaces. And as we do our work, we must recognize and keep all the principles of these 3 C's in mind. So thank you very much.
Thank you very much, Professor Bogansolo. I'll over now to Dr. Tochi. She's going to talk to us about the country perspective.
Okay, good morning, colleagues. I'm really happy that I'm taking off from where Prof stopped to share the Nigerian experience. I don't know how to close this. Can you go to the next slide, please? I would love to share my screen myself.
Tochi, go ahead and share your screen so that you can, yeah.
Okay, thank you. Okay, so to share our Nigerian experience with the IPC part of the COVID-19 response. So the World Bank data shows that Nigeria has a population of 195, approximately 196 million people. We have 36 states with the Federal Capital Territory as one. So sometimes we say 37 states, but it's actually 36 states with the Federal Capital Territory, which is Abuja. We have 774 local government areas, and the health facilities we have in the country, approximately for primary healthcare facilities, we have about 34,786. For secondary level facilities, we have around 5,513. And for tertiary health facilities, we have around 164 facilities. Currently, our records show that we have 98 treatment centers in the country and 29 laboratories across the country that can make a diagnosis of COVID-19. The epidemiologic picture as of June 2nd, 10 a.m., that's the epi curve. Like everybody has indicated, we are still on the rise. Every state in the country, with the exception of one, Cross River, has reported COVID-19 cases. And we currently have 10,578 cases, 3,122 cases with 299 deaths. So approximately the case fatality rate is at 3%. To show the age-sex distribution, males are obviously more affected than females, and the age group that's most affected is between 31 to 40 years. We now go into really the philosophy behind our national COVID-19 IPC response. We believe that we must sustain IPC strengthening in the long term beyond the COVID-19 pandemic. And indeed, we had already, as a country, at the IPC program at the NCDC, we were already working at institutionalizing and sustaining IPC, both nationally and at facility level, before the COVID-19 pandemic came. So we do believe that we must continue the efforts towards sustaining this IPC in the long term. And our main health system strengthening goal is to have at least all public health facilities in the country meet the WHO minimum requirements for infection prevention and control within the next 6 months. The first case of COVID-19, the Italian, came into Nigeria on the 25th, and on the 28th of February, a diagnosis of COVID-19 was made. But before then, as part of preparedness effort, given what was going on globally, we already at the Nigeria Center for Disease Control constituted a preparedness committee. And part of the first things we needed to do was to identify and understand the readiness of health facilities across the country to cater for suspected cases of COVID-19. And one of the most important things we wanted to find out was the ability to screen, isolate, and notify and avoid contamination of their health facilities. I would love to share what we got. I'll look at this facility has an IPC focal person. You see that nearly 60% did not have an infection prevention and control focal person or team. And I'd love to link this to what Prof. Ogunshola had just finished talking about. If we look at this pie chart that shows facility has an IPC committee, responsibility and due authority, nearly 70% did not have. Then for IPC focal person or team that has a work plan on IPC activities, over 65% responded that they didn't have. So this was our starting point in planning for the COVID-19 response activities, IPC response activities. And so at that time, we set the following strategic objectives. First, to prevent and limit community transmission of COVID-19. Secondly, to prevent amplification around health facilities in Nigeria. And thirdly, to protect health workers from nosocomial infection with COVID-19. The scenario Nigeria had at that time was that we didn't have cluster of infection, we didn't have community transmission, we just had one or few cases. So that was the scenario that we were at. So we set this objective, even though we were in that scenario, but we had a long-term view that we already should be planning as if we were already in community transmission at that time. Then in March, a couple of months after we had started implementing those first set of strategic priorities, we reprioritized following our mid-action review. At this time now, we were in community transmission. Generally, we set out to, as a goal nationally, for all the pillars of the response was to suppress transmission of COVID-19 by finding and isolating all cases and tracing, quarantining all contacts, physical distancing measures, hand and respiratory hygiene, and appropriate restrictions on mass gatherings and non-essential travel. Then, for the IPC specific objectives of this broad goal, we set out now to review and enhance IPC practices in communities and health facilities to prepare for treatment of patients with COVID-19 and prevent transmission to staff, patients, and visitors. The second objective was to support health facilities and community care providers with strong evidence-based guidelines and workplace reminders. Third objective under this goal, to track personal protective equipment supply and identify IPC surge capacity and ensure rational use of personal protective equipment and other IPC supplies. For the second strategic objective goal, we had to strengthen the health system to be better prepared in areas not yet severely affected by COVID-19. This was the broad objective, the reprioritized broad objective, one other broad goal at national. Then specifically for the IPC part of it, we set out the objective to have IPC program with a dedicated trained team in place in each health facility for the purpose of preventing healthcare associated infection, yes, with COVID-19 in mind, but other healthcare associated infection, and combating AMR through IPC good practices, to monitor IPC and WASH implementation in health facilities and public places, and monitoring this compliance with standard precautions along with mechanisms with the mindset of improvement, and to institute COVID-19 healthcare-associated infection surveillance, and then to provide prioritized tailored support to health facilities and states based on IPC risk assessments and local care seeking patterns, including IPC trainings to address any skills and performance deficit. So I shared with you the two strategic goals and objectives we set over the course of this outbreak. But the point I want to make is that the response is a living response. It is not cast in stone. It is data-driven, and as scenario change and the data speaks to us, we shift. Now, a lot of discussion has gone on around healthcare worker infection. And so many people now, especially in the occupational health circles, are beginning to call for COVID-19 to be identified clearly as an occupational hazard, as an occupational disease for healthcare workers. So I'll briefly share what we are seeing with health worker infection. I love to say health worker infection in Nigeria. And the data we have here is from SOMAS. SOMAS is our main real-time online outbreak data capture mechanism. So currently, we have a total of 812 health worker infection. That's as in epidemiologic week 22. But as we looked into this data, we found that about 426 of these health workers, it appeared that their infection was not healthcare acquired. And I'll point to the fact that in many parts of Nigeria now, we are in community transmission. So it appears that the health worker infection is mirroring the community, the community transmission. Sorry, the non-healthcare acquired is 386, while the ones that appear to be healthcare acquired, we are making for ourselves as a country and hoping that other people will find something to learn from our own experience. Strengthen IPC programs across the country. It is the only sustainable way. It is the most cost-effective and efficient way. Identify state and health facility IPC focal persons and support and establish a network of IPC focal persons. Conduct policy-level advocacy to medical directors and strategic ministries, departments, and agencies, including executive and legislative arms of government, to prioritize IPC investments across the country. This has been one of our very strong points because we have the Presidential Task Force, and at the technical working group of the Presidential Task Force, we have a liaison for the State Governors Forum. So what we have done as the IPC pillar is that we have articulated all our plans for states, and through the state liaison of State Governors Forum, we have sent it to them. It was actually the governors themselves who, through their commissioners for health, constituted the state IPC program and sent us the names. So we keep reporting back now to governors. And one other thing we have done is that we have developed a document for minimum IPC requirements, including WASH requirements for health facilities in the country. And we have shared this through the same liaison person with the Governors Forum. So we consider that a very strong tool that if anybody has opportunity to do at their own national level, you should try. Deploy electronic copies of the available IPC data capturing tools through mobile app to support availability of IPC data. For instance, we developed a couple of monitoring and evaluation tools, a couple of checklists. For instance, the screen, isolate and notify audit tool, the tool we have for tracking and investigating healthcare worker infection. The tool, we have the IPC scorecard, which we use through the focal persons in health facilities and states to make sure that infection prevention and control practices are always in green. As much as possible, if this can be deployed through electronic means, no matter how simple, Google Forms, ODK forms, whatever form you can deploy this electronically, explore that. It makes it a lot easier and people find it easier to use these tools if it's deployed that way. But even if all these are not possible, please let us still use paper-based versions. But the most important thing about these audit tools is that any information you collect from anybody at health facility level, at state level, it is very important that people get feedback in the context of continuous quality improvement, because this data, we get it to make things better. So some lessons I have also learned personally, and we have learned together as a group in this response, is standardize, standardize, standardize. It is easy for things to break down. It is easy for across a large country like Nigeria to have different versions of the same thing. So at national, we saw it as our role to standardize and provide quality. An example is the training. We worked very hard to have a national standard for our training, depending on who you're training. If you're training people you think would have to go on to continue training others, for example, the IPC focal persons, we have a 3-day training agenda that mirrors the Africa CDC ICANN modules. For frontline healthcare workers, we have a 1-day training module. For treatment center workers, we have a 2-day training module. And what we have worked very hard is to bring everybody that's interested in training to come and be trained and use the same module, the same monitoring and evaluation and learning framework, and the same pre and post tests, the same reporting structure, to make sure that people who are trained across the country are receiving the same training. It is not yet perfect, but at least we are moving forward with that. Then decide on your source of evidence-based guidelines and other information. The internet is full of information, and because COVID-19 is novel, so many things, like Prof has started off by saying, what has changed since the last time we started this webinar series? A lot has changed and a lot keeps changing. So for us nationally, we have sources of information to also help us in providing guidance for the nation. And we have prioritized the following: the Africa CDC website, the WHO website, the CDC, and the European CDC. Occasionally, we look up other African countries' websites and what they're doing, for instance, South Africa, Egypt, Morocco, as much as possible to give it some of our context. Ghana too sometimes. But for us, the standard we really derive from Africa CDC, WHO, CDC, and ECDC. And manage partner engagement proactively. There's a tendency to have a lot of partners come to the table, and if it is not managed proactively, things can break down. So what we have done is that we have created a mapping tool for all infection prevention and control activities across the country, where every partner who is involved in anything infection prevention and control goes to that mapping tool and indicates exactly what action they're doing, who or what the target is, which state is this target, which level of care is this target. So we have full visibility of what every partner is doing. We know there are still gaps, but at least it gives us an opportunity to keep some kind of control over this. Utilize professional groups, associations, and networks. This has been very, very useful. Infection Control Africa Network, the societies that we belong, the Association of Public Health Physicians of Nigeria, Guild of Medical Directors, Society of Environmental and Society of Occupational and Environmental Health Physicians of Nigeria. These are very, very important, because sometimes you have a challenge that you can't find in any textbook, you can't find in any literature, and you go into your networks and realize that a publication just came out yesterday that solved that problem. One very good example was when the research came out that COVID-19 is airborne, the one again that Prof alluded to. It was in discussions in an IPC network that I was able to get, the perspective and a balanced view that helped us to manage the situation within our own context. Think IPC programs. It is easy to get sucked into rapid response, ad hoc, not planning because it's an outbreak, Yes, find a balance. Think long-term, think IPC program, because definitely COVID-19, even though it's a pandemic, even though it's an outbreak, is going to be drawn out. So even for a pandemic and an outbreak, you need to really make sure you don't create artificial structures that are not sustainable. And then coordinate your rapid response team deployments and ensure it builds subnational capacity. We were very careful in designing and deploying the IPC component of our rapid response team. And we deployed over 35 IPC rapid response team members, but they had a clear mandate to, before they exit, make sure that the state had an IPC program and that the state completely owned that process. So yes, there will be a need for rapid response teams to be deployed. But from our own experience, it is always very important that we are mindful that this rapid response team builds state capacity and results in a state-owned program and response. In spite of everything, gaps still exist. There are still suboptimal IPC programs across the country. IPC capacity of healthcare workers across the country still exists, a lot of gaps. Lack of IPC monitoring and evaluation tools across all health facilities. We are not where we want to be. We are nowhere near where we want to be. Still issues with policy backing and the political side of things. With prioritizing of IPC programs is still an issue. And all these gaps continue to inform our refining and, if you like, rejigging of our response activities. I'd like to acknowledge and thank all the partners here. Thank you very much.
Thank you very much, Dr. Tochi. I'll hand over to Wande from Africa CDC now.
Thank you very much. Thank you so much, Anna. So for the question and answers, I think what we would just like to highlight is that after this session, our experts will be available on the Telegram chat. So feel free to take some of your questions there. We will be able to answer some of them. So the first question, Tochi, thank you very much for a wonderful presentation. The first question is addressed to Nigeria CDC. It says, any specific guidance for IPC in IDP camps in Northeast Nigeria? Over to you, Tochi.
Okay, thank you very much for that question. We do not have a specific guidance for now, but we have identified it as a need on a draft. Over.
Tochi, can you hear me?
She has responded one day.
I've responded, yes. Yeah.
Okay. So thank you very much for that. I lost you there for a second, but I think you've covered the answers. So the next question, Dr. Mohammed, if you're happy to take this is directed at us at Africa CDC. It says that what is the Africa CDC's definition for frontline health workers? Thank you.
It depends. We have composition for our rapid response team. Our rapid response team will include epidemiologists, obviously, will include IPC experts and laboratory experts. We've learned a lot from our response in Democratic Republic of the Congo, where we've supported RRT, both local and international RRT in that country. And right now, for COVID, we're deploying epidemiologists all over the continent for countries who have requested, laboratory experts and also IPC experts. And in future, I think we may also look at the treatment components depending on the request from member states. For PAC specifically, we will be deploying within the next few weeks, we'll be deploying a sizable amount of community workers. For that one, we're still trying to define critically what our needs are in that space. Are we using community health workers, which is different from community healthcare workers, or even just community workers? So based on the ongoing discussions we're having right now with partners and the core Africa CDC team in Addis Ababa, we'll be able to know the exact staffing for that space that will support member states when it comes to tracing and contact tracing and some other works in the community. Over, Monday.
Okay, thank you so much. We also have experts from WHO, USCDC, Public Health England. So I will throw this question to my colleagues at WHO, Afro and Emerald colleagues. I know that you're online. So this question is just saying that from what the person understands, is there evidence of SARS? Is there evidence on the clothes of healthcare workers? I think the way the person has structured the question. So I think it would be helpful if we're able to give just a response on the SARS-CoV virus on clothes of healthcare workers. Ibet and Iman.
Yeah, hello everybody. Sorry, I lost the connection for a while. Please, can you repeat the question?
So the question is talking about our perspective on the evidence of SARS-CoV-2 virus on the clothes of healthcare workers.
On the clothes?
Yes, so I'm assuming like the scrubs and things like that.
Yeah. For the data which we are available till now, that of course the SARS-CoV is the COVID-19 virus can persist on the scrub or can contaminate the clothes of healthcare workers. So they have to enter into the room and providing the care for suspect or confirmed COVID patient while protecting their clothes, wearing gowns that may be disposable in order to not to transmit the infection outside the facility. Also we have to have a perspective for the type of procedure and risk assessment for the procedure that we have done. How long we contact the patient, how long the procedure can be in close contact to such patient. So we have, if we are working in isolation unit, the healthcare worker should carry out, put a gown, long-sleeved gowns to protect his clothes. But we are not recommending the coverall and full body suit because as we know that the virus or COVID-19 is a respiratory virus transmitted mainly by droplet and contact. It is not an Ebola. It is not a hemorrhagic fever. So the long practice of wearing a coverall or a full body scrub, it is not indicated to protect the healthcare worker in the context of COVID-19. Maybe for the hemorrhagic fever that be transmitted by blood and body fluid, but not for COVID-19. COVID-19, it is very enough to put on a long sleeve gown to protect the clothes of the healthcare worker. Over.
Thank you very much. I'll move very quickly to the next question. Elizabeth, if you're happy to take this from USCDC, it says, what are the recommendations for quarantining healthcare workers who were exposed to an infected patient without adequate PPE?
Sure. Hi, this is Elizabeth Bancroft from the U.S. Centers for Disease Control. And the quarantine recommendations currently is that if somebody had a high level risk of exposure, and so that means, as Dr. Wande suggested, they were not wearing PPE, they were in a room, for example, where a patient was intubated or an aerosolized generating procedure took place, or that they had sustained face-to-face contact with a patient, that if possible, if you have enough healthcare workers, that person should remain under quarantine for up to 14 days, and they should have regular symptom monitoring. We recognize in certain situations where there is profound spread within the community, and you might have a lot of healthcare workers who are out on quarantine under those conditions, that you don't have the luxury of being able to put everyone under quarantine for those 14 days. And then in that case, you need to make a careful risk assessment of the healthcare worker, what sort of, whether or not they can go back to work earlier than that, whether or not it's done with very careful symptom monitoring with the healthcare worker, and whether or not you can rotate that healthcare worker to non-patient duties during the time of quarantine, so that they are unlikely to expose, during a pre-symptomatic period, they're unlikely to expose any other patient. But ideally, that healthcare worker, if they meet the criteria of having a high-risk exposure to a patient, should be under quarantine for 14 days. Over.
Thank you very much. Prof. Ogunshola, this next question was actually directed at you. I know that you had replied, but for the benefit of other participants who haven't looked into the Q&A chat box, this question is, some findings are showing fecal-oral transmission, and the question was directed to Prof. to give an overview of that. So over to you, Prof.
Thank you very much. To date, there has not been any report that I know that suggests that there is fecal-oral transmission. What has been shown is that they've found viral RNA in stool. Now, that does not necessarily translate to infectivity. What you need to find for transmission is live virus, the whole virus. So it shows that there's shedding, but does not show that that is a live virus. So to date, I have not read anything, unless something has come out that there has been any validation of stool transmission, fecal-oral transmission. I haven't seen that yet.
Thank you very much. Our colleague Emilio from Public Health England, I will just pose this question to you. It says, what is the minimum PPE required for handling confirmed COVID-19 patients? Emilio, can you hear me? So, Prof, if you would like to take that question, it just says to us that what is the minimum PPE requirement for, I guess, healthcare workers handling confirmed COVID-19 patients? Over to you, Prof.
Thank you very much. First of all, let me say that depends on the amount of contact and that you need to have with the patient. I mean, you just came in and looked at them, and so you just have your mask. You don't have to wear any gown and so on. But for routine care, a gown, gloves, your mask, and your goggles. I know that in South Africa, for example, for just routine care that you're not doing any airborne generating procedure, and you're not when you have close contact with the patient. They would go in, roll their sleeve up, wear their gloves, have their masks, and wear a face protector or a goggle, and then do hand hygiene up to their elbow. They do bare below the elbow. So where I'm going is to keep remembering this organism goes in through the respiratory tract. So mask is the very minimum that you will use. And of course, you also must protect your eyes, because we do know that if there's a splash into the eye, it can pass through. There was a paper, I'm not sure how validated that is yet, but it is, should I say, it is scientifically possible that you can get COVID through a splash in the eye. So those should be covered. So minimum, you need your mask, you need an eye protector for the mucous membrane. And generally we'll say wear a gown if you're going to have routine care. And a medical mask. If you're doing airborne precautions, then certainly you need to use an N95.
Okay, thank you very much. I think I would wrap up this very brief Q&A just to really emphasize that our experts will be available on the Telegram channel. Feel free to take some of your questions if they have not been answered to the Telegram channel, and we'll be available to answer these questions. So over to you, Anna.
Thank you very much, Wande. I want to thank everybody that joined us today. We will have another session next week, Wednesday at the same time, for the next 5 weeks after today. So please join us and send us if you have any burning questions or areas you want us to touch on. The start and the end code will also be displayed. And if you do have problems, you can still email me and I'll continue it to you. My email is anna@icannetwork.co.za. All the materials will be available on the Africa CDC website and even on ICANN website. And we will also send it to everybody that is registered for this session, that they will receive the presentations. Thank you very much.